Hello everyone. Today we are going to discuss the gastric cancer as a whole and along with it because the neuroendocrine tumors of all the GI tract is hard to cover at one place. So what we will do is we will cover the gastric cancer part. Along with it, we will discuss the neuroendocrine tumors because those neuroendocrine tumors are rare one and they are mostly uh, seen in the jejunum and the small bowel and the pancreatic in the regions of the pancreas. So we have clubbed the basic part of the gastric cancer, and along with it, we will discuss the neuroendocrine tumors as wherever possible. Okay, wherever it will be needed. So, so what is the global burden of the gastric cancer? So, see, gastric cancer in the upcoming era, it has been the incidence has been increased and it has become the fifth most common cancer globally and the second most common cancer, which is leading to the cancer death. And mostly all of the countries around the world is being affected by this disease. And you all, I hope that you all know that once upon a time, the Japan was a leading country in the gastric cancer, and most of the population was affected by the gastric cancer. So Japan is the one of the very important country which has done a lot of research work in this gastric and the esophageal cancer part.
Think nets are always slow and harmless? Think again. Gastroenterhormone producing neuroendocrine cells and commonly involve the small intestine, appendix, or rectum. The clinical clue may be subtle, recurrent diarrhea, abdominal symptoms, or unexplained weight loss should raise suspicion, especially when disease has advanced. The critical step is classification. Differentiation, Ki67 proliferative index, help determine tumor grade and guide management. So, can you identify the key marker?
Yeah, so there are some molecular alterations, the genetic alterations which we are discussing about, the oncogene activation. So the HER2 gene is not only for the breast cancer, it can also be activated in the gastric cancer as well. So cell adhesion losses. See, I was showing you that E-cadherin is a molecule which helps in the cells to adhere with each other. Okay, so whenever there is mutation, it always leads to the diffuse type of cancer, and you have already seen that the diffuse cancer has the worst prognosis in the Lauren classification as well as in the Borman's classification, which is the classification for the advanced gastric cancer. So it is advanced. The term already is speaking you the advanced gastric cancer. So it is having the poor prognosis. Again, the microsatellite instability and the P53 mutations and the APC mutations, which will lead to the tumor suppressor genes. Diagnosis and staging. So the clinical presentation, the patient generally presents with the epigastric pain. The patient will have early satiety, will have weight loss because the patient will not eating much because the patient will eat like one chapati or two chapati and the stomach will be full for the day. So the patient will not consume more of the diet, and that's why the patient will lose the significant weight loss. So when it is called significant weight loss in the terms of malignancy, always remember more than 10% of the weight or the baseline weight loses within a month or within a 2 months. Okay. So that weight loss is known as the significant loss. Suppose that a patient had a weight of 50 kg and after 2 years his weight becomes like 39 kgs. So this is not a significant weight loss. You will not suspect cancer. You will rule out cancer and other.
Gastric cancer is not one molecular disease. Its biology is driven by distinct genomic alterations that define different tumor subtypes. In EBV-positive tumors, splifications, MSI tumors show hypermutation, while genomically stable tumors associated with CDH1 and RHOA alterations. And in chromosomal instability, TP53 mutations and receptor tyrosine kinase amplifications can drive tumor growth. That is why molecular profiling matters for personalized treatment.